I'm excited to present this information on initiating and conducting your own telehealth audit. My name is Angela Hardesty, and I'm here to present for eCatalyst Healthcare Solutions. eCatalyst was formed in 2007 to unite the knowledge, experience, and vision of our nation's key HIM leaders. With over 200 plus years of combined healthcare knowledge, eCatalyst provides HIM services, mitigates HIM and middle revenue cycle operational issues, advances your most important projects and strategic initiatives, working holistically with your multidisciplinary teams. Now let's get started and talk about telehealth. CMS has issued multiple temporary waivers and rule changes starting March 6th for telehealth under the COVID-19 emergency. This was done to extend maximum flexibilities to providers to ensure care to patients and expand testing. At the top of everybody's list is the fact that telehealth has been expanded significantly and is being reimbursed via these various waivers. This even includes telephone visits for patients who either don't have access to video technology or don't want to use it. Several interim rules were passed and things have moved very quickly. This is conflating several critical topics such as privacy, reimbursement, patient access to care, all under the topic of telehealth. About privacy. The temporary HIPAA waiver is allowing providers to use non-HIPAA compliant technology such as Zoom or FaceTime, and that the government will not impose penalties for this. And by the way, these companies have amped their security significantly since the beginning of the pandemic because they realize they have filled a critical role. These are often used because they are easy to use and there's wide accessibility to users. HIPAA has been relaxed but not malpractice. So understand that using telehealth should be used only when appropriate under the most considerate conditions. Regarding the licensure, under these waivers, CMS has allowed leniency for physicians to work across state lines. And telehealth locations have been expanded significantly with the originating site suspension. Essentially, the patient can be located in the home or in any healthcare facility to have a reimbursed telehealth visit. This wasn't the case before, so this waiver also results in higher reimbursement rates for those telehealth visits. Now, what is temporary and what will become a final rule? We're clearly not going backwards to where we were, and what CMS clearly understands is that the explosion of telehealth has allowed patients to stay at home, reducing foot traffic in clinics, and for providers to continue to see their patients. It was a bit of the Wild West out there in March, so we created a telehealth self-audit. This was done in order to provide a basic starting point for organizations of any size just to get a handle on what was occurring across their locations. The end game is to provide a pathway to develop informed guidelines for your specific telehealth practices. I highly recommend that you also use this to determine what metrics you will use to monitor the success of your program and guidelines. The telehealth expansion has been addressed by NCQA that governs quality measures, so be prepared and remember that your success will be based on outcomes. So you need to develop some guidelines and policies. Determine which providers are, will be, and can or cannot use telehealth, which types of patients will be treated, establish protocols for telehealth visits. At what point do you determine what is appropriate for a telehealth visit? Is it at the time of scheduling, during your tech check, or with the actual visit with the provider? For example, the provider might determine that the patient is too sick or unable to use the technology. You also need the guidelines to ensure compliance with documentation standards for telehealth visits. Many providers still have PTSD over the EMR implementations, which may have actually influenced previous adoption of telehealth because they saw that as just one more thing to do. And what is the consent procedure? Of course, what are your guidelines for billing, your E&M codes, and various payer rules? So let's just get started from the beginning. Where is telehealth happening in your organization? Although this seems elementary, regardless of the size of your organization, this is a logical place to start. I personally like starting my audits with the easiest question. It gives you a little confidence boost that you're heading in the right direction, and it invariably reveals much more complex questions. But seriously, why does the where matter? Performing a basic inventory is essential in order to manage issues such as space, connectivity, technology infrastructures. Does it meet basic compliant practices? Are there liability issues? And we also have to be aware from a collections aspect for any particular billing issues we need to monitor, such as denial management, any mitigation, appeals, rebills, charge master updates relevant to cost and service centers. Regarding the technology, what are you using for telehealth? There are most likely multiple types being used. Again, a basic inventory needs to be done, but you do need to understand the scope because the temporary nature of the current waivers. And you need to understand and establish a solid practice plan for once this pandemic is over. So take stock of your current practice, and you'll want to share this information with your IT security team and compliance department. Evaluate the liability, establish targeted and relevant messaging to the providers based on the type of platform they're using, and then you must inform your patients if you are not using a HIPAA secured source. Another word about privacy: make sure that the provider's surrounding space where they're conducting the visit is secure. There shouldn't be any visible PHI, not having any mirrors around or behind the provider, and that no one can overhear the conversations with the patient. One note is that Intermountain Healthcare is providing clinicians with basic instructions called webside manner. And the basic message is, don't do something in a telehealth visit that you wouldn't do in a clinic exam room, like eat a sandwich during a visit. So no foot traffic or people having conversations behind you, background TV like TVs and pets and kids, or wide open doors. Also, wearing the white coat gives the appearance to the patients that they are receiving the same level of professional attention that they get when they're in the office. Regarding telehealth consent forms, you should and you need to make sure it's being addressed before or at the beginning of the visit. For hospital settings, some hospitals are updating their conditions of admissions to include a telehealth section, and this would cover any bedside telehealth or remote monitoring. Your office medical assistant can get consents before the provider is engaged for an office visit. And the other thing that might be addressed in your consent are some of the housekeeping rules for the patient. These can address the best place for them to be during the visit, what to do in case of technical difficulty, and you can set some ground rules in this consent so everyone is on the same page. What is being documented and what should be documented and built out into the encounter guides or policies particular to telehealth visits. Not to get too in the weeds here, but this is a sample of items that are particular to a telehealth visit. Let's document start and stop times, particularly if time is being used to drive the level of service. Document that the visit occurred via telemedicine technology, audio or audio visual. Document the type of technology if you're not using your EMR platform, the physical location of the patient and of the provider during the visit, and name all persons participating. This might be the caregiver, a parent if it's a pediatric visit, a translator, or another family member. So just to add and combine two presentations into one, we all know that the E&M coding changes are coming January 2020 or 2021. So these office visits are being driven off of medical decision making. So why not start including those elements now? Have you done the complete technical build out for your EMR and your practice management billing solutions for telehealth? This is the IT aspect of the EMR and practice management that must be given a thorough review. Actually, assigning this piece to your IT analyst or SME is a great idea. It's extremely important that you are updating fields, templates, and appointment types. And the recommendations that I have seen for appointment types are in 15-minute increments, 15, 30, 45-minute visits. And of course, make sure that your billing codes and modifiers are built out. Who's monitoring the rules for updates in your organization specific to telehealth? 85 codes have been added temporarily, and the majority of these codes that are added are typically in-person codes. But because of the public health emergency, these had to be done via telehealth. For example, annual wellness exam, including new patient visits and office-based E&Ms, are now allowed to be billed via telehealth. So depending on the size of your organization, someone or a task force needs to be designated to lead the charge. This could be compliance, HIM, revenue integrity, or the revenue cycle management. Does your state have telehealth parity? Many states have passed emergency declarations that mandated payment parity. Telehealth payment parity under Medicare allows Medicaid programs and private payers to be reimbursed as the same rate as an in-person visit. Since this was long considered to be a linchpin to nationwide telehealth adoption, parity has spread the adoption of telehealth significantly. What type of telehealth service is being provided? So there are multiple types, and each are billed at different rates. Telehealth E&M code, this is a synchronous visit between the patient and provider. So physicians would be providing your normal telephone or audio visual, and these are all allowed under the public health emergency. The telephone E&M, this is a patient-initiated telephone service to an established patient. The virtual check-in, this is a patient-initiated brief check-in service using any form of communication technology. And e-visits, this is online communication via patient portal or email. All insurances are paying for these under the same rules and circumstances. They have mostly adopted the CMS model, and the payers are now extending this type of expansion 3 months at a time. Most of them have extended it out to December 31st. However, Medicare is extending it till the end of the public health emergency. Most payers will continue to extend through the end of the year and after the end of the year. However, private insurances have changed copay allowances as of October the 1st. So make sure that you are conferring with your private insurances what their rules are, because this month, patients will be held responsible for their respective in-office copay visits for telehealth visits, and this is new. And CMS's update at the time of this presentation is proposing a rule not yet passed to make a lot of these payment models permanent. What payers are being billed and what are their policies? This is an example of a grill that we built for one of our clients, and we recommend that every organization create and maintain for the interdisciplinary team that includes coding and billing teams, IT departments, and physicians. This is a dynamic document that will help track updates and ultimately reduce billing errors and denials. It contains the name of the payer, the CPTs approved by that payer to use for billing telehealth visits, any modifiers allowed or required, and a comment section to make notes on changes. We also recommend adding a date column to keep a log of the changes with each payer. And this should be monitored constantly for changes as needed when you get additional information for your payers, and then get the updated version out to your team. What code selection is being used by the providers? And is it relevant to their location and their specialty? Is it time-based or is it medical decision-making based? What documentation are you using to select the level of service? As most providers are still using medical decision-making at this time, they're comfortable with this. And if they're comfortable with them, let them continue. It can also get you to a higher level. And on a side note, this impacts the 2021 E&M level changes too, coming back to that again. Anytime that you can use your medical decision-making components in advance of those changes, the easier that transition will be for you. Have you built out your report based on the CPT codes and G codes specific to telehealth billing? This is a critical step, and it's something you need to do if you haven't done so already. You really need to determine your audit population, and having the report based on this information will help you to do a data analysis and focus on where audits need to be performed. You can focus on the data to drill down into areas that are already showing discrepancy or trends or risk areas. This is second nature for our HIM profession. So you need to verify that your report is casting a wide enough net to capture all of the codes used for telehealth. Because of the changes and allowances and modifications that have been released since the beginning of the public health emergency, the opportunity for rebilling previous claims exists. The big question is, do you have a plan to correct and resubmit previous claims? Based on the audits, reports, and data review, evaluate the modifiers, the place of service, and effective dates for the Telehealth during certain emergency periods Act of 2020. If you have to make changes and rebill, then you need to make a plan. And it may be because of a revised CPT code requirement or a documentation requirement that has been added by a payer. For example, in the beginning, Blue Cross and Blue Shields of Illinois wasn't specific on if you needed a video and audio or if audio was enough. Then they came back and they said that audio was adequate. So all of the audio visits, time-based audio only codes, could then be rebilled as office E&Ms based on appropriate medical decision-making documentation. So that wraps up the overview for conducting your internal telehealth audit. Thank you for spending time with me to participate in this presentation. Here's my contact information, Angela Hardesty at eCatalyst Healthcare Solutions. If you have any questions or comments, I'd love to hear about how your organization has managed the expansion of telehealth. If your organization needs assistance in evaluating your telehealth practice, conducting retrospective audits, or even providing education to your team, eCatalyst Healthcare is available to help. Thank you and have a great rest of your day.